Hello everybody, my name is Dr. Adam Rindy and welcome to today's presentation on intestinal microbial overgrowth and inflammatory bowel disease. I'm delighted to be here presenting, and I want to thank Dr. Jason Harper for inviting me to speak with you today. This is just some brief background about me. I've presented on SIBO on many occasions dating back to 2009. Presenting to the IBD community is something I've wanted to do for quite some time, and I'm delighted to be able to share some specific information as to how SIBO and intestinal microbial overgrowth relates to your condition. I have no affiliations to mention today that to disclose for this presentation. Here is the agenda for today. My goal is to explain what intestinal microbial overgrowth is, how it relates to IBD, how to get evaluated and properly tested, give you an overview of treatments, both conventionally and naturopathically, and provide you with a perspective that hopefully empowers you and does not overwhelm you and gives you some agency and tools to discuss with your gastro team to help with better managing your care. So it's important to know, and you know this better than anyone, that IBS-like symptoms exist in IBD, and even if you're in remission, it's likely that you are experiencing ongoing digestive symptoms, and those symptoms can be discussed with your team. However, there are so many potential causes of those symptoms, and as this list discusses, it can be exhaustive to think of what is driving these additional symptoms. I will say that the topic we're discussing today rises to the top in likelihood. So intestinal microbial overgrowth as a driver of digestive symptoms when IBD is in remission is a strong possibility. It is interesting to note that when in remission, 25% of IBD patients will meet the criteria for IBS. This is remission that is confirmed by endoscopy, biochemical remission, and histology. So a quarter of patients with IBD will also qualify for an IBS diagnosis. The commonality between IBD and IBS and intestinal microbial overgrowth is these are conditions that have dysbiosis as an underlying feature. Dysbiosis refers to microbial imbalances in the microbiome. The gut microbiome that we're specifically talking about today is the trillions of microbes that live in our intestine. When they become out of balance, whether it's due to overgrowth, undergrowth, or displaced growth, a term dysbiosis is used. There are many subsets of dysbiosis, which we will go through a great deal of them today. Intestinal microbial overgrowth was classically defined by the use of a duodenal aspirate measuring the amount of microbes that were present in the small intestine compared to those that were asymptomatic. SIBO patients were defined by having greater than 10 to the third colony-forming units of microbes per mil in the upper intestine. That cutoff also has been described as greater than 10 to the fifth colony-forming units per mil. But generally, this is just to give you the idea that the original SIBO diagnoses were made by culture. Since this is not commonly done, there is another alternative to understanding and defining SIBO, and that's through breath testing. Breath testing is the most common way that SIBO is both diagnosed and defined. And the North American Consensus Guidelines talks about the use of glucose or lactulose as a medium for a breath test that's designated to diagnose SIBO. And based on certain gas patterns and gas rises, there will be a criteria met or not met for SIBO. So you can see hydrogen, methane, hydrogen sulfide are the three gases of interest in intestinal microbial overgrowth. On the scene in this development is small intestinal fungal overgrowth. However, we do not have a gas that's measuring that particular scenario. We will go into these aspects in detail. Conceptually, this slide will help you understand what's taking place in overgrowth in the small intestine. So the top slide shows a normal distribution of microbia in the small intestine. If a fermentable food such as rice or beans is consumed, that fermentation would normally take place towards the ileum and the colon, so further down. But in the lower slide, you can see if there's overgrowth of bacteria, there's going to be excess fermentation of those foods in the upper intestine, creating gas, maldigestion, malabsorption, and generally an uncomfortable sensation in the upper intestine due to this hyperfermentation scenario. So this is kind of a ground view of what might be taking place in SIBO. To understand SIBO is also best learned through the lens of how not to get SIBO. So there are many things that the body naturally has to prevent that overgrowth from taking place in the small intestine. And it is important to note that people with IBD generally have many risk factors for SIBO because of the prevention parameters are not as equipped. So for example, motility can be a problem in IBD. Also, the gut immunity may be decreased in IBD due to medications or disease activity. The intestinal lining might be disrupted, and there can be pH changes in IBD as well. Peristalsis might be affected by IBD. Therefore, the risks of SIBO and IBD are strongly in place. So knowing this gives us an understanding of what we have to think about and why SIBO is so common in the IBD patient. When we're thinking about protecting against SIBO, even in IBD patients, we want to be thinking about these factors and all the tools that we have to improve the body's ability, improve the body's pH, the digestive tract's pH, improving bile acid function, improving motility, helping the gut immunity. We know there are certain microbes that are causing these symptoms, both gram-positive and gram-negative microbes. These are determined your normal gut flora. They're supposed to be there. They're not infections. They're not bad microbes. It's just that they have overgrown or displaced into the wrong areas or are in excessive amounts in certain areas of the gut where they otherwise normally wouldn't be. And so the presence of them, the thriving of these microbes are causing the main symptoms in intestinal microbial overgrowth. There are three types of intestinal microbial overgrowth to consider. Methane-related overgrowth, otherwise known as intestinal methane overgrowth. Hydrogen sulfide overgrowth, which is H2SO, and hydrogen overgrowth, which is hydrogen positive SIBO. So each of these seem to have a certain feature or flavor to them. Intestinal methane overgrowth tends to be constipation related. Hydrogen sulfide tends to be diarrheal and also associated with a flatulence that's described as sulfur odor or egg odor flatulence. Hydrogen producer can be both constipation and diarrhea. It's a little more difficult to pick up just by symptoms. Each of these particular gases have specific microbes that seem to be driving them. Hydrogen is predominantly driven by Klebsiella and Escherichia coli. Hydrogen sulfide by Desulfibrio piger. There are some other organisms related to hydrogen sulfide production. Methane is predominantly driven by Methanobrevibacter smithii, which is from the kingdom Archaea. More on these features. Methanogens are very interested. We've learned recently that they are cross-fed by microbes called, two of them are Ruminococcus and Christensen Eliaceae. These microbes provide and feed these archaea organisms with hydrogen, and the presence of them working together tends to lead to increased archaeal growth and increased methane production. Hydrogen producers we've listed, I mentioned earlier, the most common being Klebsiella and Escherichia coli. Desulfibrio seems to be the main driver of hydrogen sulfide, but Fusobacterium are also involved. And there are some more features to discuss. You'll see that IBD patients generally don't deal with methanogen problems. Most of IBD patients are going to be focused on hydrogen production issues and hydrogen sulfide production issues. SIBO is associated with so many conditions. You can see it well represented in the literature. And usually it's either a association, or it can actually be a driver or contributor to the disease process. See this specifically in Parkinson's disease. A lot of Parkinson's disease patients will test positive for SIBO, and a good deal will improve their overall symptom picture if treated successfully for SIBO. It's very difficult to treat in Parkinson's disease because there is some innate motility issues. But if you look at this exhaustive list, you'll see that a lot of the overlap of these conditions is the link to these conditions and motility disruption. So if I had one main cause of SIBO, I would say it's a motility related condition. Now SIBO, when it is in place, it does make other conditions worse, like skin conditions, depression, anxiety, even autism spectrum related symptoms. So for you, the most important thing to know is that if you have IBD, you're 9 times more likely to have SIBO than the general population, even more so if you have Crohn's disease, and 10.8 times more likely than general population. So very important to consider this. It's estimated that 22.3% of those with IBD will have SIBO. This study is very interesting. It came out in 2022 using SIBO to predict relapse in Crohn's. And you can see that people with SIBO were much more likely to relapse at 6 months, and again, even more so in 18 months. And it remains to be seen whether if you treat SIBO, if that is going to reduce relapse. However, it just makes sense from a standpoint mechanistically, but that is something that I have not seen research on yet. But it is important to note that SIBO might be part of a simmering risk factor for an upcoming flare, and it would be something to discuss with your team whether it needs to be monitored when you're in remission. IBD and SIBO overlap quite a bit as far as symptoms are concerned. IBD having much more extreme symptoms of blood and mucus and specific abdominal pain, but both will have a lot of general abdominal symptoms and irregular bowel movements and bloating and brain fog. SIBO is unique in that it seems to be made worse by higher FODMAP foods, The bloating that comes on with SIBO generally resolves overnight. When IBD flares, generally not going to be an off and on type symptom like that. However, there is enough overlap that a lot of people might get confused as to which one is causing what symptoms. They both disrupt the gut in similar ways. Both provide a source of inflammation to the gut. Both will upregulate the nervous system, making the nervous system more sensitive, more hypersensitive viscerally, and both of them can contribute to intestinal permeability, increased catecholamine or stress chemistry. IBD, let's be clear, is an autoimmune condition where SIBO is not, and IBD is going to be noticed more macroscopically on imaging and with biopsy, whereas SIBO would require some very specific research-based instruments to see the microscopic damage it's creating. So I highlighted this earlier, but not many patients with IBD will have methane or intestinal methane overgrowth. If they do, then they will likely be in the subset of ulcerative colitis, which is 4 times more likely to have methane than Crohn's disease. There's nutrient deficiencies that appear both in SIBO and IBD. The IBD is more of a nutrient deficiencies that are created by loss of minerals. SIBO is more related to fat-soluble nutrient deficiencies due to bile acid malabsorption. Both will have vitamin B12 deficiencies and vitamin D deficiencies. So imagine having both of these conditions, you're high risk for multiple nutrient deficiencies. One thing that is interesting, vitamin K and folate can both go up in SIBO due to the bacterial production of these nutrients. And so if you are being monitored for folate deficiency and you see your folate come back elevated, that might be a clue that you're also dealing with SIBO. It's important to work with someone on your team that's monitoring these nutrient deficiencies, not only from a standpoint of immune health, bone health, mitochondrial health, but also as a potential to ward off the side effects of SIBO or flag SIBO early. Albumin is a very common discussion in the IBD space. It's a marker of disease status, and that's picked up on a general chem panel. And low albumin is a marker of disease activity in IBD. And sometimes it persists to be low, even if disease activity is not taking place. And this can be related to potentially protein malabsorption. And SIBO is known to be a cause of protein malabsorption. So if albumin persists to be low in your evaluation, and even if you're in quiescent state of IBD, you might consider that SIBO might be a contributing factor. I've seen albumin increase just based on treating SIBO in IBD patients. This is another view of the different types of testing. Testing for SIBO is controversial as far as which substrate to use. There are many in the glucose breath test camp, or a whole group that's in the lactulose breath test camp. Much of the people at Cedars-Sinai in Los Angeles are more in the lactulose breath test camp. Other parts of the world only use glucose. You'll have to discuss with your team which one that they ascribe to. You probably will not be offered aspiration or culture at this time, but I imagine there will be some time in the future where smart pills are used to diagnose SIBO. There are 2 commercial tests that are known. The Trio Smart test, which measures all three gases that I've discussed about, including hydrogen sulfide, and Commonwealth, which only measures hydrogen and methane. Because hydrogen sulfide is strongly associated with diarrhea, um, it might be diagnosed if using just the Commonwealth test. But there are other ways to potentially interpret hydrogen sulfide from the Commonwealth test, and Commonwealth, I'm sure, can discuss that with you if you reach out to them. The Trio Smart, though, is the only one that I'm aware of right now that offers all three gases. These are some of the results. You'll get back a report that shows whether you have high gases in the various parts of the intestine, which gases are elevated, and if it's gases in an improper state. It is normal to have gas towards the end of the test, which is like around sample time point 9 or 10. That's usually when you've swallowed the substrate and you're blowing off gas that's 90 minutes or more into the test, and that would be where we're seeing, down here in the 120 minute, 140 minute and beyond. That's usually in the colon region, which we would expect there to be high amounts of microbes. This is the Trio Smart format, showing their three gas representation. Like I mentioned, there are scenarios where you can pick up on abnormalities that have different explanations. It's important for you to have your team read closely the Trio Smart test and the breath test to make sure that it's been looked through carefully. There are conundrums and various other interpretations that can be made based on your clinical picture. Following test preparation to a T is very important, especially avoiding antibiotics 4 weeks before testing. So the guidelines are fairly uniform and adopted amongst labs, and so they would give these guidelines to you in the package, but very important to follow these to get accurate results. Treatment. So there have been some main protocols developed. I'd say Cedars-Sinai is one of the forefronts of developing some SIBO protocols. After testing positive, they'll most commonly use an antibiotic called rifaximin. Brand name is Xifaxan, for 14 days, 3 times a day. And then after a period of 4 weeks, repeating the test. If the test is abnormal again, they do consider retreating again or trying other combinations of treatments. If the breath test is normal, it's important to start a prevention protocol, which we'll talk about later, but that usually involves prokinetic medications. If not responsive to treatment, going back and looking at some of those other causes that we talked about on the first slide might be a good idea at that point. So as mentioned, antibiotics are the conventional treatment of choice. Rifaximin is the primary antibiotic used. The reason that's used primarily is it's been studied, obviously, but also it's non-absorbable, and it seems to target these gram-positive and gram-negative microbes that are most associated with SIBO, and doesn't get systemically absorbed, so it's not likely to be a drug that you become resistant to very easily. And also it's not broad spectrum, so it does leave a good deal of your microbiome intact, which is great. But in IBS patients, it seems to help 40 to 50% of the patients by normalizing breath tests after using it. So it has a pretty good success rate and significant symptom relief too in IBS populations. It's been studied in one study that I know of for IBD patients listed here, and these IBD patients, 147 were tested, and 62% of them tested positive for SIBO. They were given rifaximin with probiotics, or rifaximin alone, or rifaximin or probiotics alone. So what they found is those treated with the rifaximin on board had improvement in disease index status. Harvey-Bradshaw index decreased in Crohn's. In ulcerative colitis, the partial Mayo score decreased. And so that was a significant improvement in overall management of these conditions by treating SIBO. And it did mention in the trial that surgeries and strictures and potential like colectomy surgeries made one more at risk for SIBO. It is not common that IBD patients will have methane overgrowth, but if they do, there are some specific protocols used for methane overgrowth using combination antibiotics, rifaximin plus neomycin. For hydrogen sulfide, I'm seeing the protocols being still developed, but the most common one is rifaximin in combination with bismuth salicylate, which is also known as Pepto-Bismol. So these combinations seem to help. I have not seen any major studies come out. However, this is a developing protocol. Also, some anecdotally talk about rifaximin plus metronidazole being used in combination. There are a whole host of other antibiotics that could be used in SIBO. Most of them are more broad spectrum and absorbable, so I caution against wide adoption of these protocols. However, it is important to note that Xifaxan is difficult to get approved by your insurance, and it is quite expensive if it's not approved. So these may be options that you could take and trials that you could take before or eventually qualify for Xifaxan. Some dietary approaches have been used as monotherapies, including the elemental diet. I'd pay attention to this space because if you're wanting to avoid antibiotics altogether, there is some up and coming data that an elemental diet, which is a specific liquid beverage diet, that is difficult to follow, but it can normalize breath test, and it might be an option for those wanting to avoid antibiotics. Otherwise, dietary wise, most people use diet as a complement to treatment, including the low FODMAP diet or the low fermentation diet. These are the most common diets that help reduce symptoms of SIBO and may help with just overall success in treating SIBO. From the herbal antimicrobial standpoint, we have lots of herbal medicines that are antimicrobial and can be used as replacements for antibiotics, conventional antibiotics. However, there isn't a ton of research. This is one chart review that was done using various formulas that are commonly purchased over the counter, even purchased on Amazon. These particular formulas were compared head to head with rifaximin and comparatively performed similar. This was not a controlled study. However, it was a chart review study of patients who had been on these formulas and retested for SIBO after being on these formulas. And the success rate was determined by these authors as comparable to Xifaxan. And we do use these formulas quite a bit. I've even seen them showing up in some, being prescribed in some gastroenterology offices. So something to research as an alternative. A lot of people want to know if they can treat SIBO with prebiotics, probiotics, postbiotics, or if they should avoid these types of things while having SIBO. I will say there's one really well-researched probiotic in SIBO called Saccharomyces boulardii. That is one that may improve outcomes when combined on treatment. That is actually a yeast antibiotic. So I'm sorry, yeast biotic. So it's actually a yeast, not a bacteria. And prebiotics might worsen symptoms in SIBO. Postbiotics, which are like butyrate and short chain fatty acids, um, they may be helpful in calming SIBO or calming inflammation. Um, However, right now we don't have a whole lot of evidence that taking probiotics alone will treat this condition. There is one probiotic that works really well for methane based on these research studies. It's called Lactobacillus reuteri. Something to note, this is a specific strain, DSM 1790 17938. So big take home message though, with all this treatment, you could be feeling better symptomatically and the SIBO could be gone, but the recurrence rate of this is highly likely, probably more likely even in Crohn's. So having a preventative strategy after you treat is very important. One of the ways to do that is through the use of support to the migrating motor complex, which is the mechanism of the gut that keeps the upper intestine sterile. So there's certain natural factors that promote the migrating motor complex, such as meal spacing and avoiding grazing, but there's also medications that can also stimulate this, such as low dose erythromycin, which is used in a lot of protocols, and also a medication called prucalopride, which is another promoter of motility. So keeping the migrating motor complex functioning well after SIBO treatment is very important for a prevention strategy. Some more information about potential prokinetics. Naturopathically, if you have not been to a naturopath or a functional medicine doctor, you'll know that we do some additional assessment beyond the breath testing. We might look at enzymes and bile function, also intestinal lining markers. We might also look for other microbes or infections in the gut that might be contributing to SIBO. We might also look at other drivers of inflammation, such as food sensitivities or immune markers. So a lot of times when we're using SIBO, it's part of a larger puzzle of gut repair that we're trying to promote. This is a classic gut model called the IFM-5R model, where the practitioner will take you through various phases of healing your gut, from removing the SIBO to replacing factors that led to the SIBO, and reestablishing a healthy microbiome, balancing the gut lining, and reimbalancing lifestyle and dietary habits to prevent reoccurrence. This is like a classic model. Most of us who have been practicing a while will do offshoots of this model. This is kind of the one I do, which targets all the factors that are involved in leading to SIBO. I try to address each of these aspects in my treatment plan to help people prevent reoccurrence. Once I've treated them and stabilized them, I'm looking at really helping the gut overcome factors that might lead to reoccurrence. Also, we know very specific nutrients that address the biology behind SIBO. This is probably more than this presentation needs at this moment, but this tells you that we just have various enzymes and herbal medicines that can affect each of these functions that sometimes will incorporate tannins and alkaloids and phenols from plants can work really well as antimicrobials. Prokinetics like ginger and artichoke leaf extract can really work well for motility. So closing thoughts, where does this fit in the bigger picture of things? So whenever a patient comes to me with IBD, I'm always thinking, what is my role and how do I support this patient best? I really respect the overall team approach to IBD, and I know that there's only so much that the GI team can get to. I'm thinking about how to make remission work really well and keep people in remission. And address things that are taking place in the remission state that could potentially lead to a flare, reducing triggers, establishing a healthy small intestinal microbiome, and reducing dysbiosis when in the remission state can only be, in my opinion, a very helpful practice and something that is very worthwhile to focus on. Through that, we can reduce nutrient deficiencies, potentially reduce the use of steroids, potentially reduce flares that don't resolve, that result in surgery, and hopefully it's a way of leading to prolonged remission. So hopefully this primes your interest and give you something that you can bring up with your care team. And I hope that looking at SIBO is something useful, and managing your microbiome is something that becomes a common practice in the inflammatory bowel disease community. So thanks for attending. Here's where you can find me. I really appreciate you being here. I encourage you to send me a message if you want on my website. Listen to my podcast that has a number of various health topics that are related. I write often on these topics on my Substack and also post frequently on Instagram. Thanks again, and I hope you all have an enjoyable conference.